You all just give me a quick thumbs up if my audio video is fine. Everyone, I hope you all can hear me, and we have a lot of live classes which I can see right now. So I hope this session will also be very beneficial for all of you. There are many students who were requesting for the PYQs, and that is why I thought of starting with a session where I can discuss a lot of PYQs. So welcome all of you. I am Dr. Chesta, your NEET PG educator on Unacademy. Please get ready for the NEET PG All India mock test on 26th of February 9 AM. You can enroll in this free test by using my code, that is Chesta10. We are also introducing the notes of NEET PG, so you can get the notes of all the 19 subjects and get your access of 1 year of Unacademy subscription. We have two types of subscription. One is Plus, which gives you an access to Unacademy live classes, and another is Iconic, which give you an access to both Unacademy and Prep Ladder. Now I congratulate to all the students who have cleared their FMG exam. For the month of February, we have a lot of free sessions, the test series available, so requesting all of you to please be a part of it. We have special classes which are the free live classes available on the platform. I do take every day at 2:30 PM, so requesting all of you to please join my free sessions. Two very important batches starting today. One is the FMG batch of 4 months and another is next batch for 1 year for the next 2023 exam. Requesting all of you to please join this. We are also offering some discounts which is only valid till today. If you use my referral code Chesta10, you can avail these discounts. So please use this referral code Chesta10. Now we have two types of subscription. One is Plus and another is Iconic. Plus give you an access to Unacademy classes, and a very hot selling subscription is a 3 month. You'll get a 1 month free if you use my code Chesta10. Additional 10% discount is also seen on these subscriptions. Now we have a lot of MCQs for the today's session. Starting with the first one, they are all one-liners. So requesting all of you to please answer all these questions. Investigation of choice for diagnosis of Epidermolysis bullosa. Okay, so it's a very easy question, and we have discussed the very similar question in the today's 2:30 PM session also. Please remember, the investigation of choice for Epidermolysis bullosa is electron microscopy. It is not DIF. There are many students who have marked it wrong. The correct answer is electron microscopy. Why we do not do DIF? Because DIF is only positive in the conditions where you have autoantibodies, but you do not see any autoantibody here, and that is why the correct answer is option number 2. Now let us very quickly go to the other questions. Very important session today we have this. Yes, I hope the images, everything is visible to you. A 22-year-old farmer with history of trauma over his left foot while walking barefoot on the field 3 years back, he has presented with development of warty growth over the left foot. On doing the biopsy, the report reveals these type of brown colored bodies. What is your diagnosis? What is your diagnosis? What is your diagnosis? Anyone? Very nice, Shashti. Now, a patient who presented with a history of trauma, warty growth on the foot, and a very characteristic bodies. If you examine this, can you see this brown colored or copper colored body? This is known as a very classical copper penny body seen in the patients of Chromoblastomycosis. Here the name of the fungus is Phyllophora, so it's a very classical Chromoblastomycosis. Next question. What is the correct answer of this question? So here the question says that patient develops bulla on elbow, knee and the sacral area. We have crust formation, we have scarring and melia, no photosensitivity and negative family history. On DIF, the immunoglobulin deposition IgG at dermoepidermal junction was seen. There is no blood vessel involvement. What can be the diagnosis? What is the probable diagnosis? Please remember the answer to this question is yes, it is EB acquisita. So it is a mechanobullous disorder because only the trauma prone sites are getting involved. But because DIF is positive, it cannot be congenital mechanobullous disorders like EB dystrophica, EB acquisita, etc. It has to be an acquired condition, and that is EB acquisita, where you have IgG antibodies against collagen 7. You have IgG antibodies against collagen number 7. Clear, all of you? Next, what is the answer of the next question? 24-year-old patient has multiple small hypopigmented macules on the upper chest back for the last 3 months. Macules were circular, arranged around the follicle, and they make coalesce to form large sheet. What is the correct answer here? Shrishti, Prince, all of you. Now here the image, if you look at the question, it is a very classical macules. At the periphery they are discrete, but in the center actually they are confluent. They are combining together to form large areas of involvement. You also see fine scalings with a history of recurrence. All these points toward the diagnosis of Pityriasis versicolor. What is Pityriasis versicolor? It is a fungal infection secondary to Malassezia species. Malassezia globosa, Malassezia perfora. And if it is fungus, it has to be a KOH examination. Can anybody tell me what do you see when you do a KOH examination? What will you see in a patient? Very nice. You will see a very characteristic spaghetti and meatball appearance, which is also known as banana and grape appearance. Spaghetti and meatball, which is also known as banana and grape. Very, very nice, all my dear students. Next question. 22-year-old female with multiple asymptomatic hypopigmented macules all over the body. Anyone? Sai, Shrishti, Prince. Very nice, all of you. Now again the picture is very similar to the last image which we have seen. Very similar to that. But remember that this is not a case of Pityriasis versicolor. The reason why this is not Pityriasis versicolor is, just look at the question. Wood's lamp have a red appearance. In Pityriasis versicolor it is yellow. In vitiligo it is ivory white. In PIHP you will not see any fluorescence. Second is, it is not responding to emollient and steroid. That is again something which is against the diagnosis of the first three options. So the only correct option which we have is option number 4, that is progressive macular hypomelanosis, which is actually a condition which occurs secondary to propionibacteria acne, and it is mainly located at the follicular opening, and that is why you see perifollicular orangish red appearance, and that is why you see perifollicular orangish red appearance. Next question is on your screen. Anyone? Simply on the basis of history also, please remember, see, the presence of hypopigmented lesions on the trunk, you can have a lot of DDs. But to come to a single diagnosis, you anyway have to do some investigation. It could be a KOH, it could be Wood's lamp. Otherwise, presentation of hypopigmented lesions on the trunk, the differential diagnosis can be Pityriasis versicolor, progressive macular hypomelanosis. Even in post-Kala-Azar dermal leishmaniasis, you can see the hypopigmentation. So there are a lot of differential diagnoses, but to come to a diagnosis, you have to do some investigations. Next question, Prince, Shrishti, Sai, what is the answer here? Amazing, all of you. Now you can see that there is a very classical honey colored crust. It was preceded by flaccid bulla with purulent content. Purulent means infective, turbid content. It has to be a case of Bullous impetigo, which occurs secondary to the Staphylococcus aureus infection. It occurs secondary to the Staphylococcus aureus infection. So a 9-year-old girl with appearance of multiple vesicles enlarges to form a flaccid bulla with purulent content. They rupture to leave behind brown crusting. Which of the following is the correct answer? Option number 4 is the correct answer here. Okay, so I hope everything is clear till here. Next question. Prince, Sai, Shrishti, there's an image. Let me just focus the image first. Can you see this depigmented patch which is present on the nail? Little bit is present on the nail of the little finger also. So the two nails shows some defect. Which of the following will clinch the diagnosis? What is that thing which will help you diagnose? Very nice, Prince, Shrishti. This is a classical case of onychomycosis. That is fungal infection of the nail. And it is actually the nail plate which is most frequently affected. To clinch the diagnosis, you have to do a KOH mount and you have to demonstrate the dermatophytic hyphae. Dermatophytic hyphae if it is because of dermatophyte. You can even demonstrate the yeast, the budding yeast, which is a very classical feature of candidal onychomycosis. So very important, when you see few nails, not all, only few nails with discoloration and thickening, it has to be a case of onychomycosis. Next question is a 28-year-old male with multiple grouped papules, vesicles on elbow, knee, buttock, upper back associated with itching. DIF shows dermal tip deposition of antibodies. What is the most likely diagnosis? Lot of images given. Hint is also given in the question. We have 4 options. Prince, anyone else? Sai, Shrishti. Which of the following will be the correct answer? Amazing, amazing, all of you. Good. So in a 28-year-old male, if you have multiple grouped vesicles over these areas, you have to think about dermatitis herpetiformis. Now dermatitis herpetiformis, it is actually a cutaneous manifestation of gluten sensitive enteropathy. 90% of the patients of DH have underlying gluten sensitive enteropathy. Because of this, they develop antibody against tissue transglutaminase, and these antibodies will cross react with epidermal transglutaminase, which is present over the dermal papillary tip. This will cause inflammation, deposition of the antibodies, which is of IgA type, only over the dermal papillary tip, and that is why you get granular deposits, which is very important. Okay, there is not linear, it is granular deposits of IgA over the dermal papillary tip. Next question. Next question is on your computer screen. Anyone can tell me the answer here? 25-year-old male with bulla in the skin, erosions in the oral cavity, intraepidermal acantholytic blisters, the most likely diagnosis here would be, very nice, bullous pemphigoid, erythema multiforme, dermatitis herpetiformis, or pemphigus vulgaris. Now, for solving these questions, I always tell my students that mark the dermoepidermal junction. So, if you mark the dermoepidermal junction, which is somewhat like this, it is somewhat like this. So, this is a dermoepidermal junction. And can you see that the split is present just above the basement membrane zone, just above the basement membrane zone, that is suprabasal. And we know that there is one condition where you have suprabasal split or you have oral cavity lesions associated, classical row of tomb appearance. This is a case of pemphigus vulgaris. Very nice. Here you see the antibodies against, the IgG type of antibodies against desmoglein 3 more frequently compared to desmoglein 1. There is no antibodies against the hemidesmosome or any of the component of dermis or basement membrane. The prognosis is very poor if the patient is not treated with the drugs, or if patient is not given a proper treatment, he may land up into the complications. So very important, pemphigus vulgaris. Next, an 18-year-old boy with well-defined annular lesions over the buttock with central scarring that is gradually progressive over last 8 months. What can be the diagnosis here? This is again a similar question which we discussed in the morning session or afternoon session today. Anybody can tell me the answer here? Annular lesion which is seen on the buttock. You have scarring which is gradually progressing over the last few months. What can be the diagnosis here? What can be the diagnosis here? Anyone? Oh, very nice. Now, if you remember, few days back also we have discussed this, that whenever you get an annular lesion, you have to think about 3 conditions or 3 things. One is annular lesion with central scarring, with central crusting, and with central clearing. At least remember few DDs of all of them. The most common differential diagnosis for annular lesion is, with scarring, it is cutaneous TB, lupus vulgaris. Lupus vulgaris. For central crusting, it is cutaneous leishmaniasis. And for cutaneous leishmaniasis, it is the volcano ulcer or the dum-dum fever, Delhi boil. So cutaneous leishmaniasis. While for central clearing, we have dermatophyte, which is Tinea infection, Tinea corporis, fasciae, cruris, etc. So please remember the DDs of annular lesion is important. Here the answer is option number 3, that is lupus vulgaris. Next question, 10-year-old boy with painful bogey swelling of the scalp, sinuses with purulent discharge, easily pluckability of hair, multiple lymph node. Which of the following would be the most helpful for making the diagnostic evaluation? Very nice, all of you, amazing. 10-year-old boy with painful bogey swelling of the scalp, sinuses with purulent discharge. Which of the following would be the most helpful for making the diagnostic evaluation? The answer to this question is option number 3. And here the diagnosis is kerion. What is kerion? Please remember, kerion is a type of Tinea capitis. We have broadly classified Tinea capitis into inflammatory type, and non-inflammatory type. Inflammatory type and the non-inflammatory type. What are the examples which you read under the inflammatory type? You have 2 examples. One is the kerion, where you have painful boggy swelling. Another is Pemphigus. It is the type where you see yellow colored cup shaped crust, which is known as scutula. In non-inflammatory, again you have 2 types, black dot and grey patch. The black dot variety is very popularly known as endothrix, while grey patch is very popularly known as ectothrix. And why they are called so? Because in the black dot type of tinea, you have fungal spores inside the hairs. If this is the hair, you have multiple spores which are present inside the hairs like this. While in the grey patch, which is the ectothrix, if this is the hair, you will see fungal spores on the surface. You will see fungal spores on the surface like this. You will see fungal spores on the surface like this. Is this clear to all of you? Now, why it is known as black dot? Because whenever you have so much of spores inside, as soon as the hair comes out of the scalp, it breaks, because due to spores it becomes very fragile. So you will see multiple broken stump, which will give you an appearance of a black dot. While in grey patch, because of the presence of the spores outside, you will see greyish appearance. So please remember, the non-inflammatory type is black dot and grey patch. Kerion classically presents with a boggy swelling like this. You have lot of inflammation. Can you see the erosions, crusting, and you can see there is scarring type of alopecia which is seen here. Very, very classical of kerion. You can see discharging sinuses, etc. The causative agent of kerion is, anyone? It is trichophyton mentagrophyte and trichophyton verrucosum. Favors, where you see the yellow colored scutula, causative agent is trichophyton Schonlein. For black dot tinea, it is trichophyton violaceum and trichophyton tonsurens. And for grey patch type of tinea, it is microsporum species, which is most frequently Microsporum canis. So please remember, we have different type of Tinea capitis. We do get a lot of question every year. I've seen few questions from this particular topic. In any of the exam, you will get a question. So please remember the Tinea capitis and its causes. And if it is a fungus, the test you will do is a KOH mount to look for the presence of the dermatophytic hyphae. Next question. Next question. Anyone? Srinivas, Dental Q, Shrishti. 40-year-old woman with 8-month history of erythema, swelling of periorbital regions. No muscle weakness. What can be the most likely diagnosis? Anyone can tell me the answer here? Yes, the correct answer of this question is option number 2, that is dermatomyositis. Now if you look at this image, let me just focus on this image. You can see that there is a lot of erythema around the eyes and the forehead. Is this clear? Second is, we have a lot of redness which is seen. Please give me a quick thumbs up if you understood. Yes. So this characteristic rash which you see around the eyes, it is known as heliotrope rash. And this erythematous plaque which you see on the knuckles, this is known as Gottron's papules and Gottron's plaque. Both these features, they are very specific to a condition which is known as dermatomyositis. But in the question it says that you have no muscle weakness. So do you get dermatomyositis without muscle weakness? The answer is yes. There is a variant which is known as amyopathic dermatomyositis. Amyopathic dermatomyositis. Okay? We have amyopathic dermatomyositis where you have no muscle involvement but you have characteristic cutaneous rash. The antibody which you see here is anti-Mi2. The antibody which you see very frequently here is anti-Mi2. And it tells you that there are more risk of having the cutaneous lesion compared to that of muscle weakness. So this is a variant of dermatomyositis known as amyopathic dermatomyositis. Child develops non-blanching macules, papules on the lower extremities, mild abdominal pain, skin biopsy shows IgA deposition, perivascular neutrophilic infiltrate. What is the most probable diagnosis? Which is the most probable diagnosis? Anyone? Anyone? Yes. So here you can see that patient presents to you with palpable purpura. There is a triad of palpable purpura. You have a triad of palpable purpura, and what else you can see here? In addition to palpable purpura, the features which is given is abdominal pain. Then you have IgA deposits which is seen. All these features point toward the diagnosis of Henoch-Schonlein purpura. It is not Wegener's. What is the presenting feature of a patient of Wegener's granulomatosis? Wegener's granulomatosis classically presents with features of upper respiratory tract, lower respiratory tract, features of glomerulonephritis. They will not present with abdominal pain. So there is a difference between both these conditions. Please remember the answer here is option number 3, Henoch-Schonlein purpura. Okay, very nice all of you. The next question is here on your screen. What is the correct answer here? Very nice. Now again, please look at the image. There are a lot of vesicles which are present on the sun exposed area, and you can also see that the healing is occurring through scarring. Okay, healing is occurring with scarring. This is a case of porphyria cutanea tarda, which is an acquired porphyria, occurs due to the inhibition or damage to the enzyme uroporphyrinogen decarboxylase, and it classically presents with the vesicles and bullae over the sun exposed areas. Next question. Next question is on your computer screen. Next question is on your computer screen. Anyone? Very nice. So patient comes into the clinic with unilateral blue speckled patches. Look at this image. I think this image is self-explanatory. When you have a bluish lesion unilaterally present over the distribution of trigeminal nerve with involvement of mucosa, very important. This is a very classical feature of Nevus of Ota. If the same thing happens on the posterior aspect, of the shoulder, that is over the scapular region, can you tell me what is the name given to that? If same thing occur over the posterior aspect, that is over the shoulder area just above the scapula, it is called as Nevus of Ota. And if same thing occurs over the lower part, that is the lumbosacral region, you will call it as Mongolian spot. Next question is on your computer screen. A 27-year-old sexually active male develops a vesicular bullous lesion on glands soon after taking tablet paracetamol for fever. Lesion healed with hyperpigmentation. What is the most likely diagnosis? Very nice. Anybody else want to answer? Dental Q, Ashutosh, Shrishti, Srinivas. The answer to this question is option number 3. Fixed drug eruption is a drug rash which is a very localized form of drug rash. It occurs on the same site whenever patient takes the culprit drug. The question is, what is that site? Please remember, the most common site for development of fixed drug eruption is mucosa. Can be oral mucosa, can be genital mucosa. And if it occurs over the genital mucosa, just look at the appearance, very well defined erythematous lesion. If it occurs on the skin, it heals with hyperpigmentation. So that is also one of the very important features which you have to note in these individuals. Next question is given on the computer screen. Anyone can tell me the answer here? I can see you, a lot of you with a very easy question. 15-year-old male with presentations like the one shown in the image. Red firm papules on the face, mainly around the nose and near the mouth. Further examination reveals some lanceolate hypopigmented macules on the trunk, hypopigmented lens-like lesions. So can anybody tell me what are these hypopigmented lesions? This one. These are ash leaf spot. And what are these lesions on face? These are adenoma sebaceum. And this is a very, very classical description or example of tuberous sclerosis. Now, what is tuberous sclerosis? Also known as Bone-Willis disease. It's a genodermatosis which presents classically with a triad of epiloia, that is epilepsy, then we have loss of intelligence, and A stands for adenoma sebaceum. A stands for adenoma sebaceum. So what is epiloia? Epilepsy, loss of intelligence, and adenoma sebaceum. Very, very characteristic. Okay. It is an autosomal dominant condition with a lot of systemic features like cardiac rhabdomyoma or angiomyolipomas, dental cyst. You can see subependymal tumors, cortical dysplasias, etc. So you have a lot of systemic features also which is seen in these individuals. Okay, what is the correct answer of this question? A male with cryptorchidism presented with large scales on the body flexures. Skin biopsy shows hypergranulosis and steroid sulfatase deficiency. Very nice. Male with cryptorchidism presents with large scales on the body flexures. Skin biopsy shows hypergranulosis and steroid sulfatase deficiency. What is the probable diagnosis? What is the probable diagnosis? Anyone? The correct answer of this question will be, what will be the correct answer of this question? The answer is option number 3. So please remember, we have two types of ichthyosis which everybody needs to know. Which is very frequently asked in your exam. So just write it down, the two types of ichthyosis. One is the autosomal dominant type, which is ichthyosis vulgaris, the commonest one. And another is X-linked recessive type. So these are the two types of ichthyosis which you get in your exam very frequently. What is the main problem in ichthyosis vulgaris? You have deficiency of a protein which is known as filaggrin protein. Deficiency of filaggrin protein. While in X-linked ichthyosis there is steroid sulfatase enzyme deficiency. You have deficiency of steroid sulfatase enzyme. While in ichthyosis vulgaris the filaggrin protein is deficient. First, very important point. Second is, how will it present clinically? Please remember, ichthyosis vulgaris will present clinically as small, light colored, fine scales which are distributed all over the body, distributed throughout the body, distributed throughout the body, with classical sparing of flexures. So it is present everywhere, but the flexures are normal. So that is something which is very important for ichthyosis vulgaris. But for X-linked recessive ichthyosis, what is the clinical presentation? You will have large, dark color, thick scales which is distributed throughout the body, present all over the body. There is no flexural sparing here. There is no flexural sparing which is seen here. It is present uniformly throughout the body. No particular sparing which you see in this patient. Moving to the third very important point. Now what is the third very important point here in the patients of ichthyosis vulgaris is, there is associated atopic dermatitis. You see atopic dermatitis in these individuals. While in the patient of X-linked ichthyosis, you will see association with cryptorchidism. You will see associations with cryptorchidism and corneal opacity. You will see associations with cryptorchidism and corneal opacity. And what else? Option number 4, when you do a histopathological examination, you will see hypo or agranulosis in ichthysis vulgaris, but in the patients of X-linked ichthysis you will see hypergranulosis. Stratum granulosum is proliferated. So that is how you differentiate ichthysis vulgaris from X-linked recessive ichthysis. Very important, frequently seen question. Here the answer is option number 3. There is cryptorchidism. The scales are large, involving the flexures, hypergranulosis and steroid sulfatase deficiency. Everything points towards the diagnosis of X-linked recessive type of ichthysis. Next question. What is the answer here? Anyone? What is the correct answer here? An 8-year-old boy from Bihar presented with a 6-month history of an ill-defined hypopigmented, slightly atrophic macules on the face. What can be the most likely diagnosis? Very nice. So if you have atrophy, you have to mark it as indeterminate leprosy, because in Pityriasis alba you will see fine scaling, itching, but no atrophy. So that is one point which differentiate both of them. Another question, it's an easy one. GK, Dr. Richpal, Sam. 8-year-old boy with no history of consanguinity in the parents. Mother reports blisters, peeling off of the skin. Similar history in the previous child. What can be the diagnosis? And it proved to be fatal in the previous child. So what can be the diagnosis? Very nice, all of you. Amazing. The correct answer of this question is option number 3. It's a case of mechanobullous disorder. And the mechanobullous disorders, they are congenital conditions known as congenital epidermolysis bullosa. Another question is here on your screen. You can see an image attached. Let me just move this image a little on the left. Good. Tell me the answer. 20-year-old male Ramu who developed multiple ulcers on the prepuce glands, which are painful, suppurative. What is the answer? Very nice. I think majority of you have given me the correct answer. Whenever you see multiple painful ulcers with undermined edges and a short incubation period, always think about chancroid. Why it is not herpes? Because in herpes, always remember that you will get a history of recurrence or presence of preceding vesicles. If nothing is given, the answer should be chancroid, which is because of Haemophilus ducrei infection, Next question is on your screen. A 45-year-old sportsman who have noticed a small nodule over the upper lip. The nodule is pearly white with central necrosis and telangiectasia. Which of the following is the answer? Very nice. It's a straightforward image based question. I think nothing we need to know here. It's a very easy question. Yes, this is a case of basal cell carcinoma, and here in this image you can see the rodent ulcer. Initially it presents with a nodule, but later it ulcerate to form a slowly growing ulcer with beaded margins. Can you see the beaded margins? And if you look more carefully, you can see that there are everted margins also. The next thing is, it is very common towards the inner canthus. So this is the eye, this is the nose. You can see that it is very common towards the inner canthus of the eye, which is the more frequent location for development of basal cell carcinoma. Moving to the next question. Pseudo-isomorphic phenomena is seen in. Pseudo-isomorphic phenomena is seen in. Anyone can tell me the answer? What is the correct answer here? Very nice. The pseudo-isomorphic phenomena, which is also known as pseudo-cobnus. Pseudo-isomorphic, which is also known as pseudo-cobnus, it's a very, very classical example of warts. While the cobnus phenomena or the isomorphic phenomena, it is very classical for vitiligo, psoriasis. For vitiligo, psoriasis, what else? Even lichen planus. Vitiligo, psoriasis, and even lichen planus. Okay, so we have two types, pseudo and true cobnus. Here they are clearly asking about the pseudo one. Richpal GK, what is the answer here? Max Joseph space in the histopathology is a feature of. Anyone? Very nice. Max Joseph space is a feature of lichen planus. In lichen planus, the cutaneous feature, the histopath feature is, in stratum corneum, we see orthokeratosis. What is orthokeratosis? We have hyperkeratosis without parakeratosis. Hyperkeratosis without parakeratosis. Okay, hyperkeratosis without parakeratosis. Then we have stratum granulosum, which shows wedge shape hypergranulosis. Wedge shape hypergranulosis. What else do we have in these individuals? In these patients, we do see presence of sawtoothing of rete ridges. Then we have hydropic degeneration of stratum basale cells, and these degenerated cells will form colloid bodies, cevate bodies, or cytoid bodies, and these bodies will get absorbed with time, leaving behind the empty spaces, which is known as Max Joseph space. So these bodies will get absorbed to leave behind the empty spaces known as Max Joseph space. We also see a thick band of inflammatory infiltrate, the T lymphocyte at DE junction, which is known as interface dermatitis. So all these features are very, very classical for the histopathological examination of lichen planus. Next question. Next question. We have only 10 more minutes left in this session, so please do answer it very quickly. Only 10 more minutes left. Recurrent oral ulcers, erythema induratum, recurrent genital ulcers, superficial thrombophlebitis. Which of the following is the correct answer? Anyone? Very nice, all of you. Please remember, Behçet's disease will have erythema nodosum. It is not erythema induratum. So the correct answer here is option number 2. The cutaneous lesion which you get in a patient of Behçet's disease is superficial thrombophlebitis. You can develop lot of furuncles and you can develop erythema nodosum, not erythema induratum. What is erythema induratum? Erythema induratum is actually the id eruption or hypersensitivity reaction secondary to cutaneous tuberculosis or systemic tuberculosis. So hypersensitive reaction to the tubercular focus. Because of lot of inflammation, for example, if it is the lung TB or if it is a GI TB, that inflammation can cause the release of mediators into the blood and it can lead to distant presentations like erythema induratum. In Behçet's, you see erythema nodosum. What is the answer? Which of the following is a true association? Again, frequently discussed. Which of the following is a true association? It's a frequently discussed question. Very nice. Which of the following is the true association? The correct answer is psoriasis plus metabolic syndrome. All of the following infections present with maculopapular rash. What is the next answer? Dengue, rubella, shigella, measles. Dengue, rubella, shingles or measles. Very nice. The answer is shingles, which presents with grouped vesicles, not macules and papules. It presents with grouped vesicles. Which of the following gene mutation leads to Darius disease? Which of the following gene mutations lead to Darius disease? Anybody can tell me the answer? Anyone? Wes, very nice. Please remember, Darius disease is ATP2A2 while ATP2C1 is for Hailey-Hailey disease. So I think it's an easy question. You just need to know that there are two different conditions. This is for Hailey-Hailey disease. Next question is here on the computer screen. Anyone can tell me the answer here? Anybody can tell me the correct answer here? The characteristic microscopic feature of bullous pemphigoid is? The answer is option number 4, subepidermal non-acantholytic blisters. Acantholysis means splitting of the stratum or splitting of the cells of epidermis, that is keratinocyte separation. You do not see any keratinocyte separation in the subepidermal disease. So the correct answer is option number 4. It is not option number 1. Crystalline malaria is because of obstruction 2. Crystalline malaria is because of obstruction 2. Again, it's an easy one, so not a very difficult topic. Anybody can tell me the answer? Crystalline malaria is because of, yes, the answer is, it is the eccrine sweat gland defect where the obstruction occurs at the level of stratum corneum. Early eruption of secondary syphilis are all except. Can you tell me the answer here? You can see everything except what? Very nice, Dr. GK, Dr. Richpal. Ashutosh, Sam, Dental Q. You will never see pruritic lesions in a patient of secondary syphilis. You can get all the features, papules, macules, symmetrical, asymmetrical, pleomorphic, polymorphic, monomorphic, everything can be seen, but you will never see itching. You will never see vesicles in a patient of secondary syphilis. So please remember, this is a very important feature. Hutchinson syphilitic triad includes all except what is not seen in a patient with Hutchinson syphilitic triad. It's a very commonly asked PYQs. We have seen the same question being repeated so many times. Hutchinson syphilitic triad includes all except notched incisor, nerve deafness, interstitial keratitis, Clutton joint, etc. Hutchinson syphilitic triad include all except. Please remember, the correct answer of this question is option number 4. Clutton joint is not a part of Hutchinson syphilitic triad. It is not a part of Hutchinson syphilitic triad. Which among the following is the most common type of psoriatic arthritis? Very simple. These are one-liners, so I am expecting everyone to answer it very quickly. Which among the following is the most common type of psoriatic arthritis? I hope you remember that 5% of psoriatic patients develop arthritis, and it is more frequent in those where you have HLA-B27. But the question is what type you see. Psoriatic arthritis, arthritis mutilans, asymmetrical oligoarthritis. Very nice. The answer to this question is very correct. You all are absolutely right. The answer to this question is option number 3. Asymmetrical oligoarthritis is the correct answer here. Commonest association of paraneoplastic pemphigus. Commonest association of paraneoplastic pemphigus is what? Anyone? Paraneoplastic pemphigus is a pemphigus where you see underlying neoplasm. The cutaneous lesions are polymorphic lesions, various morphology. It is very frequently associated with these 4 types of malignancies, but the question is, which is that commonest one? The answer is option number 3, absolutely right, which is non-Hodgkin's type of lymphoma. The most frequent drug implicated in drug-induced pemphigus. The most frequent drug implicated in drug-induced pemphigus, what is your answer? Very nice. Please remember, the drug-induced pemphigus which occurs because of steric hindrance between the 2 common group, that is the thiol group of the drug. It interacts with the thiol group of the desmoglein, and both these interactions, it occurs in a patient who takes a drug penicillin. So penicillamine is the most common drug. We have other drugs like penicillin also, captopril also, but here we are discussing it as option number 1. Which of the following is the rarest variety of pemphigus? The commonest is Pemphigus vulgaris, but which is the rarest variety? Anybody? Pemphigus vulgaris, Pemphigus vegetans, Pemphigus foliaceus, or Dermatitis herpetiformis? Which of the following is the correct answer? Amazing. Very nice, all of you. The correct answer of this question is option number 2, that is Pemphigus vegetan. Here you see vegetative growth on the flexures. You do not see the bulla like that of vulgaris. You only see the vegetative growth. So with this we are done with the today's session. I hope this session was beneficial for you. I request all of you to please subscribe the YouTube channel, that is Let's Crack NEET PG. Please subscribe the YouTube channel Let's Crack NEET PG. We also have a Telegram group with the same name, so you can use you can download the app, and you can download the Telegram and you can follow us on this group. If you want to take Unacademy subscription, please use my code, that is Chesta10. Don't forget to hit the bell icon so that you get all the notifications of my classes. Don't forget to give the thumbs up if you like this class. And if you want any more topic to be discussed, you can just write it down on the